Greetings and welcome to Riverside Methodist Hospital. My name is Dr. Tom Boes, and I am the Internal Medicine Residency Program Director here at Riverside. On behalf of our faculty, residents, and medical education staff, I'd like to thank you for your interest in the program. The information provided will allow you to compare and contrast this program with the other residencies you're also considering. During this overview, I'll be describing the interview day experience, the Riverside Medical Campus and Hospital Profile, the Graduate Medical Education Department, the Internal Medicine Faculty Support, our Faculty Mentorship Program, the program curriculum design, and the clinical rotations. I'll describe our didactic education and the new Medical Education Conference Center, clinical simulation experiences, and our point-of-care ultrasound curriculum. I'll review how residents are evaluated in this program and how we prepare our residents for the board examination. For those applicants considering a fellowship, I'll describe our fellowship preparation and match success rate. And finally, I'll discuss the scholarly activity opportunities available in this program, including clinical research and quality improvement projects. The virtual interview experience this year will utilize the Thalamus interview platform with a WebEx meeting format. Each applicant will complete 4 15 to 20-minute interviews selected from 2 80-minute interview blocks, which will be offered on each interview day. A virtual lunch hour meeting will be provided on the day of the interview and allow applicants to meet with several of our categorical residents who will describe their experience here at Riverside and of course be available to answer your questions. A 15-minute virtual hospital tour will be available to review the relevant facilities available here at Riverside. This program overview is designed to provide a comprehensive description of the Riverside residency experience and will answer many of the most frequently asked questions. Our interview team this year will include myself, 2 of our associate program directors, and our 2 chief residents. I'd like to spend the next several minutes describing the Riverside Hospital campus. Riverside is a one-campus residency program. By that I mean that all the required inpatient and ambulatory rotations, as well as most of the clinical electives, can be completed right here on this campus. The 5 interconnected inpatient buildings include 800 private rooms and 4 critical care units. Our freestanding resident ambulatory clinic is where the residents will complete both their longitudinal clinical experience as well as the subspecialty outpatient clinics. This bird's eye view will provide a better perspective of the Riverside campus. On this map, all of the colored buildings except the purple area represent the interconnected inpatient hospital buildings. As you can see, the medical education office is centrally located in the hospital on the first floor in the yellow area. When you combine the inpatient admissions, emergency department visits, hospital transfers, observation patients, surgical admissions, and the large volume of outpatient visits, Riverside represents the 5th busiest one-campus patient care facility in the United States. This provides an excellent opportunity for our residents to draw upon for their clinical learning experience. Most of our outpatient facilities are located in the northeast quadrant of our campus. Our freestanding resident outpatient clinic, known as community medicine, is a short 5-minute walk from the main hospital, as indicated by the red line. The Riverside Community Medicine Clinic supports the residents' longitudinal and subspecialty clinics. The didactic conferences provided by our outpatient faculty occur in a large conference room on the second floor of this facility. The Outpatient Cancer Center, located in the purple area, is adjacent to the residence clinic and is connected to the main hospital by an underground tunnel. The Bing Cancer Center supports the diagnostic evaluation and medical management of our oncology patients. Located just north of the resident clinic is the McConnell Heart Health Center. The McConnell Heart Health Center supports a number of preventive health clinics, including a hyperlipidemia clinic, a diabetic education and wellness clinic, and a heart failure management clinic. The center also features a full-service exercise facility. The facility includes weightlifting and aerobic exercise equipment, an indoor track, a basketball court, rooms for yoga and dance, and 2 indoor heated swimming pools. Our residents are provided with a free membership, which allows full access for the use of the facility, which is open 7 days a week. Riverside is an independent academic medical center, which combines the features of a community hospital and a tertiary care facility. Our hybrid model combines the desirable attributes of a community program with the clinical learning experiences provided in a larger tertiary care medical center. We are committed to both graduate and undergraduate medical education. Affiliation agreements with 4 medical schools here in the state of Ohio allow 3rd and 4th year students to rotate on our teaching services. Our residents gain valuable experience developing their teaching skills working with these students. 8 independent ACGME accredited residency programs collectively support training for 140 residents here at Riverside. The remainder of this presentation will describe the many important features of this program. I am a graduate of the Ohio State University College of Medicine. I completed my residency right here at Riverside and also served as a 4th year chief medical resident. I completed my fellowship training in Boston at the Leahy Clinic Medical Center and the New England Deaconess Hospital. Upon completing my fellowship, I returned to Riverside and established a private practice in pulmonary and critical care. My 7 colleagues and I are dedicated to supporting resident education in the intensive care unit, on the pulmonary consult service, and in the pulmonary subspecialty clinic. I served as the transitional year program director here for 10 years, and for the past 17 years, I've been the categorical and preliminary medicine program director. The core faculty collectively form the foundation of our residency program structure and function. Each of these individuals have a specific area of special interest and expertise, which contribute to our residents' training and professional development. I'd like to spend the next several minutes describing our program curriculum. Several years ago, we transitioned to our current 4+2 curriculum schedule model, and it's been a huge success. The 4+2 model alternates 4 weeks of inpatient rotations with 2 weeks of ambulatory medicine. Our nighttime rotations for floor and ICU call coverage are integrated into the inpatient blocks. Residents select their vacation weeks from the ambulatory blocks, which are symmetrically distributed throughout each academic year. The categorical PGY1 inpatient rotations include 3 blocks of hospital medicine, 2 4-week blocks of critical care medicine, 2 2-week blocks of floor night float, and 1 2-week block of ICU night float. Either 2 or 4-week blocks of cardiology, pulmonary medicine, nephrology, and endocrinology. Each resident also has 1 block of an elective rotation. This example will illustrate how the inpatient and ambulatory blocks are incorporated into the 4+2 model. In this example, the black boxes indicate the ambulatory weeks, while the colored boxes represent the inpatient rotations. In this example, intern B might start with a 4-week block of hospital medicine, followed by a 2-week block of ambulatory, and then a 2-week block of night float, followed by a 2-week block of hospital medicine, and then another 2-week block of ambulatory medicine, followed by a 4-week block of critical care. All residents have the opportunity to rotate through 4 hospital medicine teaching services. Residents complete 1 block of clinical medicine during each of their 3 years. They rotate through the Med 1 and COPC hospital medicine services in their 1st and 2nd years, and on the geographical accountable care unit in their 3rd year. 2 of the hospital medicine services incorporate medical students, and the services are capped at 14 patients to ensure a balance between service and education. The accountable care unit experience allows a 3rd-year resident to spend a 4-week block working with an APP under the direction of a hospitalist on a geographic closed unit. The resident is responsible for 8 patients and works collaboratively with the interdisciplinary team assigned to this unit, including a case manager, social worker, pharmacist, and respiratory therapist. A typical day in the general medicine services begins with a checkout from the night team, which occurs between 6:30 and 7 a.m., and concludes with a checkout and handoff to the night team between 4:30 and 5 p.m. each day. The mornings are equally divided between time for pre-rounding and attending teaching rounds. A half-hour lunch is followed by a noon conference, which occurs Monday through Friday of each week. I'd like to spend the next few minutes describing the nighttime medicine floor coverage experience. As previously mentioned, each resident completes two 2-week blocks of floor night coverage each year. The hours are between 5 p.m. and 7 a.m. The floor night coverage team includes a senior and junior supervising resident and 3 interns. They are responsible for the teaching service coverage and admissions to those teaching services. They also provide Code Blue coverage outside of the intensive care unit. Residents complete their required critical care rotations during the first 2 years in the program. Additional elective rotation opportunities are also available during the second and the third year. Residents complete their critical care training in one of our 2 medical intensive care units. This 30-bed unit is geographically divided to provide 15 patients for each team. Each team includes a teaching attending, a supervising resident, and 2 interns. The interns complete 12 to 14-hour day shifts and are guaranteed a full day off every 6 days. Each categorical resident also covers 1 night call during this rotation. A typical day in the ICU begins with a handoff to the day team, which occurs between 6 and 6:30 a.m., and concludes with a handoff back to the night team between 5 and 6 p.m. Pre-rounds occurs between 6:30 and 9:30, followed by teaching rounds, which include the attending physician, the residents, medical students, case manager, pharmacist, and a respiratory therapist. Didactics are in the early afternoon on Monday through Friday during the first week of each block. Our residents have an outstanding opportunity to participate in a variety of invasive procedures under the direct supervision of either an upper-level resident or attending physician. By the end of their first year, most categorical residents will have participated in 8 endotracheal intubations, 5 to 10 central venous catheter placements, and at least 8 arterial catheter insertions. They also have the opportunity to participate in both thoracentesis and paracentesis procedures. The ICU also offers an opportunity for the residents to gain valuable ultrasound experience, assisting with both procedures and the physical examination. An attending physician provides coverage for each team between 7 a.m. and 6 p.m. each day. An in-house intensivist is also available in the intensive care unit to support the supervising resident and the intern on the ICU night rotation. The intensivist is available for new admission checkouts as well as procedure and Code Blue supervision. The didactics included in the ICU curriculum include respiratory failure, ventilator management, sedation and analgesia, sepsis management, and the evaluation and management of shock, including the use of vasopressors. During the week prior to the ICU rotation, each intern participates in a 1/2 day orientation, during which time they receive training and experience in airway management and endotracheal intubation. They also receive training and gain experience with central venous catheter insertion using bedside ultrasound. Subspecialty consult service rotations are incorporated into each year of the curriculum. Cardiology and endocrinology is included in both the first and the second year. Pulmonary medicine and nephrology occur in the first and third year. Medical oncology is in the second year, and gastroenterology in the third year. Infectious disease and neurology consult service electives are also available in any of the 3 years. Residents are provided with an average of 10 weeks of elective time in both their second and third year. These electives can be selected as either a 2 or a 4-week experience. Away electives are also available upon request. I'd like to spend the next few minutes describing the didactic education experience available in this program. Our didactic education can be described as comprehensive, highly structured, and well organized. Our didactic education includes a variety of different conferences, which are incorporated into our morning or noon conference templates. Many of the conferences are interactive, including Journal Club, Clinical Diagnostics, Evidence-Based Medicine, our weekly board review conference, and our monthly EKG and chest X-ray interpretation conferences. The ambulatory conferences occur during the ambulatory blocks in the community medicine clinic and are provided by our outpatient faculty. In response to resident feedback, our morning conference schedule was significantly reduced this year in order to mitigate conference fatigue and improve resident wellness. Our first and second year residents on the inpatient blocks are only required to attend the Wednesday morning case conference, which occurs between 7:15 and 8 a.m. All residents on their ambulatory blocks participate in a morning ambulatory conference on Thursday mornings provided by our outpatient faculty. The grand rounds presentations provided by our second year residents as part of their scholarly activity are presented live only to the core faculty and are recorded for the residents to view online at a later date and at a time of their convenience. The Wednesday morning case conference allows the residents with an opportunity to present an undifferentiated case. Residents participating in this conference work in teams to develop a differential diagnosis and then narrow that differential based on a review of the labs and imaging provided. The majority of our didactics are incorporated into the noon conference schedule template. These conferences occur between 12:30 and 1:15 each day. Each month, the 8 core lectures and Wednesday board review conferences are focused on a specific specialty. The core curriculum schedule is structured to provide the residents with an organized exposure to all of the subspecialties and general medicine during the course of each academic year. On Thursdays, residents rotating on their ambulatory block participate in an ambulatory conference, while those residents on the inpatient services participate in our diagnostic lecture series. A variety of interactive conferences are also included in the Friday noon conference schedule. Our Medical Education Conference Center opened just 2 years ago and is for the exclusive use of our residents and medical students, and includes a computer technology lab as well as a variety of classrooms to support resident education. The large conference room in this center is used for our Wednesday morning case conference and most of the noon conferences. The clinical medicine team uses the intermediate classroom for their daily teaching and table rounds, and our pulmonary service uses one of the small conference rooms for their teaching and table rounds. The computer labs provides access for our residents to complete the electronic medical record. Clinical simulation plays an important role in the resident training experience, and I would like to spend a few moments describing the opportunities available in this program. Our simulation center, located on the 4th floor of the hospital, supports a wide variety of simulation activities. A dedicated clinical skills lab is used extensively for invasive procedure training. This includes hands-on training for critical care procedures such as arterial line insertion, central line placement, and endotracheal intubation. A virtual intensive care unit room in the center supports simulation training for the evaluation and management of ICU patient care emergencies, as well as the weekly Code Blue training exercises. Additional simulation activities incorporated into our resident training experience include communication skills, rhythm recognition, and our point-of-care ultrasound curriculum. Our point-of-care ultrasound curriculum was initiated several years ago and has continuously evolved with annual enhancements under the direction of our Associate Program Director for Hospital Medicine, Dr. Sanjay Patel. The curriculum includes basic diagnostics, the use of our POCUS simulation model, and the opportunity to gain hands-on experience imaging live patient volunteers in our simulation center. We recently introduced the application of portable point-of-care ultrasound imaging into our resident teaching rounds on the clinical medicine and pulmonary consult services. I would now like to describe the resident evaluation process used in our program. Our residents receive formative verbal feedback as well as written evaluations. The evaluations are confidential and are completed electronically following the completion of each rotation. Our evaluations are designed to be competency-based and include specific comments to identify areas of strength and areas for improvement. We recently streamlined our evaluations with an emphasis on the inclusion of these specific comments to reinforce what the resident has done particularly well and what they need to work on to further improve their performance. The updated evaluations also provide an opportunity for the resident to receive an assessment of their development in the core competencies and subcompetencies, or so-called milestones. A resident's demonstrated level of performance within each specific milestone is described along a continuum of 5 levels of proficiency using one of the 9 points of reference as seen in this example. Milestones in this specific rotation evaluation example include not only patient care, but also diagnostic reasoning skills, clinical knowledge, and responsiveness to feedback, professional behavior, ability to complete assigned tasks, and documentation skills. The residents' individual evaluations are then integrated into a semi-annual milestones report developed by the Program Clinical Competency Committee. The milestones provide the resident with feedback regarding his or her professional development along 20 subcompetencies based on the 6 core competencies. The resident is able to review their milestones report during the semi-annual Program Director Resident Performance Review. I want to spend a few minutes describing how we prepare our residents for their board certification exam, which is taken a few months following their graduation from the program. The weekly board review conference serves as the backbone of our board certification support process. The weekly board review conferences on Wednesdays begin in late July and continue through the end of May each year. Each week, 12 interactive board review questions are discussed with an invited faculty specialist who provides color commentary. We use the Medical Knowledge Self-Assessment Program board review questions. The Medical Knowledge Self-Assessment Program is supported by the American College of Physicians and serves as the core textbook for our program. Our residents are provided with the entire MixApp package, which includes the written books and the electronic version, which can be uploaded into the resident's smartphone, tablet, or PC. It also includes a supplementary board basics book and 2 new electronic teaching tools known as virtual diagnosis and electronic flashcards. Our senior residents also participate in a weekly senior resident board review conference, which is facilitated by 2 of our associate program directors. During this interactive conference, residents are assigned specific content to be shared with their colleagues, and again utilizes the Medical Knowledge Self-Assessment Program questions. Our Associate Program Director responsible for resident board preparation, Dr. Linda Lemaster, has developed a handbook which she updates annually and is another tool used by our residents. This handbook represents a collated collection of faculty pearls of information provided during the weekly board review conferences. I like to refer to it as Cliff Notes for the ABIM exam. Finally, for those residents interested, we do provide a reimbursement for up to $2,000 to attend an approved virtual board review conference during their PGY3 year. In October of this year, we received the results of the American Board of Internal Medicine certifying exam, which was taken in August by our 16 graduating residents this past June. I am both pleased and proud to report that for the 4th consecutive year, we have had a 100% pass rate. At this time, I would like to discuss the support we provide in this program for those residents interested in pursuing a subspecialty fellowship program, and then describe the success our graduating residents have achieved in obtaining high-quality fellowships in all of the internal medicine subspecialties. As a graduate of this program and former chief medical resident who completed a fellowship, I am committed to providing the priority and support required for fellowship preparation and advice. This support begins with the resident's faculty advisor and is further supplemented by an assigned subspecialty faculty mentor who directs the resident into relevant scholarly activity projects and offers advice regarding specific fellowship programs. Our Associate Program Director for Fellowship Preparation is Dr. Daryl Cottrell. A former endocrinology fellowship program director, she meets with the residents interested in a fellowship twice during their first year and again in the fall and winter of their second year to provide a roadmap specifically outlining the preparation needed to be successful in obtaining a fellowship. In addition, she conducts a mock fellowship interview prior to the resident's interview process, which occurs for fellowships during the fall of their PGY3 year. Finally, we offer strong support for scholarly activity and clinical research, which I'll describe in a few moments. At this time, I would like to take a few moments to describe and review our graduating resident fellowship match performance. In 2014, 9 of our residents were accepted into fellowship programs. 5 of those residents, as indicated by the red asterisk, obtained the fellowship program of their first choice. The residents highlighted in blue have actually completed their fellowships and returned to Riverside and are now part of our teaching faculty. In 2015, 6 of our residents matched into fellowships. 5 obtained their first choice, and 3 have also returned to Riverside upon completion of their fellowship training and are also now part of our teaching faculty. In 2016, 7 residents matched into fellowships, 3 of whom obtained the program of their first choice. In 2017, we actually had 12 residents match into fellowship programs, over half of whom obtained the program of their first choice, and 2 of whom, having completed their fellowships, have also returned to Riverside and are part of our teaching faculty. We have also matched 7 residents into hematology and oncology fellowships, 8 into hospice and palliative medicine, 1 into gastroenterology, 9 into infectious disease, 3 into geriatric medicine, and 3 into sports medicine. An important part of our fellowship match success can be attributed to the strong scholarly activity support provided in this program. One important component of our commitment to scholarly activity is the requirement that all residents submit an abstract for a potential oral or poster presentation during either their second or their third year in the program. For each of the past 10 years, we have placed 12 to 17 residents in the Ohio Chapter American Scientific Assembly abstract competition. Our strong faculty support for resident Scully activity includes our associate and assistant program directors, Dr. Kim Jordan and Dr. Jay Anderson, along with our clinical research specialist, John Elliott, and our research outcomes coordinator, Emily Stansberry. All four of these individuals have office in medical education and are readily available and accessible to support resident Scully activity, including their clinical conference and grand rounds presentations, abstracts for IRB research projects, data collection, poster and oral presentation preparation, and journal publications. All PGY2 residents are required to present a grand rounds conference and provide an evidence-based review on an approved topic of their choice. Our residents routinely participate in local meetings, such as the OhioHealth and MD Anderson Annual Columbus Cancer Conference and the OhioHealth Research Day. Riverside has been recognized by the Ohio American College of Physicians as one of the top 2 residency programs in the state for the percent of abstracts accepted relative to the size of our program. This past year, 14 of our residents were accepted for presentations at the Ohio Chapter ACP meeting, and 1 was accepted for an oral presentation. Our residents are also often invited to participate in national meetings, such as the annual American College of Physicians meeting, which is held in April of each year. This concludes my portion of the program overview. Dr. Dave Seipert will be providing a 20-minute discussion describing the ambulatory training experience available in our program. I look forward to meeting each of you during the interview process, and I wish you great success during the upcoming interview season. Thank you.